All right, good morning, everybody. Welcome to Wednesday's class. I hope everyone's doing well. I hope that the review session last night was well attended and was useful for you, those of you that were able to stop in. There was no additional program for today other than a program that had some tips for studying and preparing for the exam on there for you. So no additional reading or anything for class today. We are going to today talk about joints. We're going to wrap up joints. I thought about starting on muscles today. That's our next unit. But I'm just going to hold off. We're just going to wrap up joints today, and that's going to be it. I don't want to start a new unit right before the exam. It kind of doesn't make sense. I want to remind you that the material we talk about today won't be on the exam. It'll be on the next exam, but it still kind of makes sense to just finish up what we're talking about here, also because this is relevant to what we covered in lab this week. So again, the last couple weeks there's been some nice overlap between lecture and lab. And yeah, so today's agenda looks like this. I want to review your ticket out from Monday, as we normally do. And then I have a review activity for you, typical class structure here. We're going to talk about joints, and then I just have some reminders. I don't even have a ticket out for you today. That's what it's going to be. So, leaving class on Monday. Joe?
Sorry, all the reading they had to do for joints, I think it was like for Monday. Is that all fair game for the exam? Or is that stuff that we covered?
That's a great question. I appreciate you asking that. Only the topics that we've covered in class so far will be on the exam. And I'll tell you now, there might be a multiple choice question or a few multiple choice questions about joints. I won't have any long answer questions about joints. The focus will be other material. Okay. So any reading that correspond to what we covered through Monday, which is just like the introduction to joint, the different kinds of joints, I might ask you a multiple choice question or two about that, but won't be the major focus of the exam. No. Thanks for asking that. Other questions before we get to your ticket out from Monday? All right, I like to ask these kinds of questions. With what bones does the tibia directly articulate? I meant to animate this, but that's okay. Here are the results. Remember, the tibia is the primary bone of your lower leg, or shank, or crus, and it articulates with, about half of you said the femur, which is correct. It articulates at the knee joint with the femur, of course. With the fibula, now remember you have a proximal and a distal articulation with the fibula, so it actually has two joints with the fibula. And then with the talus, which is, of course, this large, the most superior of the tarsal bones. And that is the only bone that articulates with the leg. It articulates with both the tibia and the fibula a little bit on the side there. A few of you put calcaneus. Remember, the calcaneus is your big heel bone. You can't really see it here, but there's no direct articulation there. A few of you put the coxal bone. Remember, the coxal bone is your hip bone, and so the tibia is far from your hip, so no articulation there. And nobody put the other tibia, which would be weird. I'm glad nobody picked that. A good number of you, though, did pick patella. And so this is a little bit of could be a little confusing. Remember, the patella is up here, and the patella technically only articulates with the femur. It slides across the head of that femur. Now, I know it's very close to the tibia here, but it doesn't actually it's not part of a joint with the tibia. So keep that in mind, that we don't have a direct articulation between the tibia and the patella. The patella only articulates with that distal end of the femur. Questions on that? So you might guess you can expect questions like this on the exam for sure. And so make sure, when I ask you, make sure you're thinking about both proximal and distal ends of a bone, if it's a bone in the limb. So with that in mind, go ahead. Let's got a review activity here on a piece of paper. Identify structures A through G. I don't have a timer set up, but take a couple minutes. I'll see when everyone's done writing. Just refresh your memory going back to the shoulder girdle. You don't have to draw. Yep, you can though. So that certainly won't hurt. But for right now, just make a list of A through G and list what parts of the scapula those are. Are you comfortable over in that chair? There's a spot here and back there if you want, but okay. As always, do as much as you can from memory, and then go ahead and look it up if you need to. See a lot of people still writing. Give you another minute. And so this is a good example of the kind of question you can expect on the exam as well. So remember, we're doing this as review, but also it's a little quick self-assessment for yourself. If you know all these off the top of your head, you're like, oh yeah, A through G, piece of cake, then you're good shape. If this is a bit of a struggle for you, then make sure you go back and restudy that section. You're familiar with these. Mm-hmm. Yes.
Sorry. That's a femur and that one. Literally the tendon. This one's right. Is there a tendon that connects at the glenoid?
It's a great question because they're similar structures, but there is not.
I can't. Is there a reason? That's what I didn't know.
Well, it's a little bit unsure what that ligament does. If it provides structural support, but also there's an artery that runs through there.
Oh, okay.
And so part of the potential benefit is that it allows increased circulation to the head of the femur.
Yeah.
But we're not really sure exactly what.
Oh, okay.
But there's not one on the shoulder.
Capitis.
Capitis. Mm-hmm. Yep. Mm-hmm. All right, let's look at the answers here. So A is your supraspinous fossa. So remember, a fossa is a big flat area. This came up in lab. So make sure you know what that is. Given that you have three fossa, actually fossae, not sure what the plural of fossa is. There are three fossa on the scapula. You have the supraspinous fossa, the infraspinous fossa, which is up, and then you have the subscapular fossa. So remember that this is going to be this is a scapula. This is a right scapula from the posterior view. So this is me standing like this. This is what my right scapula looks like. Remember that spine is the posterior. You can feel that spine. Just go ahead and give yourself a good shoulder massage there. That spine, G, probably most of you got that. That one's a little self-explanatory. And then just remember, you have a fossa above that. Supra means above. Supraspinous fossa. And then you have a fossa below the spine. Infraspinous fossa. Infra means below. So the fossa above the spine, fossa below the spine. Then you have a fossa flat area on the flip side. So this is, again, the right shoulder blade, but this is looking like this. And so this surface here is against the ribs on your back. Not directly against the ribs, but it's facing the ribs, right? And so we call this the subscapular fossa because it's, I guess, below the scapula or behind the scapula. So those are the three flat areas you should know. Supra and infraspinous fossa and the subscapular fossa. And then you have G, the spine here. I'll get your question in a second, Dan. The other three important features you should know are B and C. So we have the acromion right here, which is this process that sticks out kind of laterally, and then we have this funny process called the coracoid process that kind of goes out and kind of curves back. It has this kind of funny shape, and that's an important attachment point for a number of muscles. Now remember, your acromion is where your clavicle articulates as well, up here. And so you've got an articulation there. And also, the glenoid cavity is right here. Now the glenoid cavity is that kind of flat curved area. It's like a very shallow bowl. You can't really see it too well from either of these angles. But that, of course, is where the proximal end of the humerus articulates, and that's your shoulder joint. So make sure you've got those 7 features down on the scapula. Dan, you had a question?
Yeah, 2 questions.
Yep.
So, is the subscapular fossa called the subscapularis?
That's a muscle, actually.
Okay.
Yep, and the subscapularis is actually a muscle. That's right here.
Okay.
And we'll cover that next week. Or probably next week.
Okay.
Yep.
And then the glenoid cavity, I heard that it's like, it was called like the glenoid fossa.
Yep, sometimes it's referred to as that. If I ask you what it is and you say glenoid, you can say fossa or cavity. Either way is fine. It's somewhere in between. A cavity is like more of like a pit or rounded area that is deeper. A fossa is more of a flat area. The glenoid is kind of in between a little bit, so you can refer to it as either. Mm-hmm. Good. Other questions? Scapula. All right, let's get back to joints then. So we were covering joints on Monday. We're going to wrap it up today. Joints are the articulations of your bones. And so this is all review from Monday, but just to get your brain thinking about this, remember we classified joints 2 different ways. The first was their functional classification, which describes how much they move. And for that, we have 3 categories. We have synarthroses, which are joints that don't move at all. We have amphiarthroses, which are joints that move a little bit, but not too much. And then of course, we have diarthroses, which are what we commonly think of as joints. They're joints that move a lot, like your elbow and your knee, et cetera, et cetera. So all of your synovial joints are diarthritic joints, meaning that they're freely movable. So 3 functional categories of joints. And then we also looked at 3 structural categories of joints. We have fibrous joints. So these are joints where the bones are connected by dense connective tissue. Then they don't move much, if at all. So they can be synarthritic or amphiarthritic, depending on how much movement is there. We have cartilaginous joints, which are joints that are connected by cartilage. And so these are, again, not very movable or just movable a little bit, synarthritic or amphiarthritic. Then we have synovial joints, which are the most complicated joints structurally. And they're called synovial because they're surrounded by a fluid-filled cavity that's between the bones, and that contains something called synovial fluid. And we'll look at that shortly, but it provides lubrication, but also provides a space for nutrients to get to the cartilage in the joint and things like that. So that's all review from Monday. We talked about some different kinds of movement that could be produced, and we went over this in lab yesterday. Gliding, angular movements, and rotation. We looked at this and we had a good time playing Simon Says yesterday. I hope that you all went home back to your friends and family and told them you played Simon Says in your upper level human anatomy class. Now, we started breaking these down, the structural classifications of joints, into more specific categories. And we started by looking at different kinds of fibrous joints. And I described to you 3 kinds of fibrous joints. Those are suture, syndesmoses, and gomphoses. So let me grab a piece of chalk here. Make sure you've got like a running list here, right? So we've got fibrous joints. We've got 3 kinds of fibrous joints. We've got a suture. We've got syndesmoses, which are when ligaments are holding bones together. So, for example, the distal end of your tibia and fibula. And then we have what's called a gomphosis, or gomphoses, I guess is plural. And that is found at 2. That's only place in the body where we see an example of gomphosis. So we went over that on Monday. What I want to do today is pick this up and talk a little bit more about the next couple structural categories of joints. The next, of course, is cartilaginous. Now, these are known as synchondroses, and basically they're when bones are connected by cartilage. And so they're usually immovable, so they're synarthritic joints. And we don't see too many examples of these in the body. We find one technically when your long bones are growing. You have that epiphyseal plate, that growth plate. That's cartilage between 2 bones. So this is technically a cartilaginous joint, right? But there's no movement there, hopefully. We also find this between the first rib and the sternum. There's a cartilaginous joint where there's no movement. So remember that first rib articulates with the manubrium of the sternum. You've got the clavicles articulating with the manubrium as well, although that's a very movable joint. But the first rib does not move at that place, and it is connected by hyaline cartilage, and so that is a cartilaginous joint that is synarthritic. Just as an aside, the rest of your ribs, where the rest of your ribs articulate with your sternum, those are synovial joints. Those are movable. There's a lot of movement between here, and you can feel like when you take a deep breath or you exhale or you move your arms back, you can feel those joints down the center of your chest where those ribs are articulating with the sternum. The exception is your first rib, which articulates with the top of the sternum, and that's a cartilaginous joint that is synarthritic. There's no movement there. We also have a kind of joint called a symphysis, or symphyses is plural, right? So actually, let me go back. I'm going to go back for 1 second and make sure you've got this. So, cartilaginous joints. We have sympchondroses. Then we have symphyses. And symphyses are amphiarthritic. Right. And they are often they're characterized by a fiber. They're bound by fibrocartilage. Remember, fibrocartilage is a type of cartilage found in a handful of places in the body, and specifically, we talked about it being found in the intervertebral discs and also in the pubic symphysis. So these are symphyses, which is a kind of cartilaginous joint where there's just a little bit of movement. So these are amphiarthritic. There can be some flexibility here. We talked about this in relation to childbirth earlier. And of course, you have a little bit of movement in those intervertebral discs between your spine. It's not a proper, it's not like a synovial joint where there's a lot of movement, but it's not inflexible either. You have some flexibility there. So we've got two kinds of cartilaginous joints. And then the last kind we'll talk about, we'll spend the most time on, are synovial. Are we good for cartilaginous? Yep, that's fine. All right, let's talk about synovial joints. So synovial joints, as I said, are the freely moving joints in your body. And so they are diarthritic, they're very movable, and they have this unique structure. And there's a whole bunch of parts of this I want to make sure you know. And this is a diagram from your textbooks. You've got access to this one. Specifically, let's walk through all of the different terms here. There's ligaments. And so ligaments are attaching bones across the joints to provide structural stability and also prevent movement in certain ways where we don't want that joint to move. So for example, you have ligaments moving on either side or extending on either side of your knee laterally, and those ligaments keep your knee joint in place and provide structure. It prevents that knee, one of the things that prevents that knee from bending in and out in the wrong plane. Those ligaments, importantly, can be what's called extracapsular or intracapsular, which simply means whether they're inside or outside of this joint cavity. The joint cavity is the space in the middle that is filled with this synovial fluid. And basically, synovial fluid is it's basically like an egg white kind of consistency. It's kind of goopy. And it serves as a lubricant between those articulations, basically to keep things greased up and moving smoothly so you don't have any friction. It increases the range of motion, decreases friction, and prevents those sensitive areas from touching each other and being painful. And this is what happens, so for example, in forms of arthritis. These joint cavities in the cartilage degrade, and you can have bone on bone when you're moving, which can be exquisitely painful. So you've got that cavity in the middle, and it's filled with this synovial fluid. We also, inside this joint cavity, the ends of those bones are covered with this articular cartilage, right? And what kind of cartilage is this? Hyaline, good. And that's hyaline cartilage that's covering the end of those bones. Again, remember, hyaline cartilage is super slick. It's slipperier than ice. So you have this combination of this lubricating fluid and this really slick cartilage covering these bones. So you can move them a lot without any binding or anything like that. We also have a layer of dense, irregular connective tissue, and this kind of forms the capsule. This kind of forms the barrier around this joint cavity. And then we have loose connective tissue that is deep to that, that's inside. That's like the inner lining of this joint cavity. So we have the joint cavity. The inner lining is called the synovial membrane. This is loose connective tissue. And then outside of that, we have this dense, irregular connective tissue that kind of gives it more structure. And what's important to note here is that it's this loose connective tissue of the synovial membrane where that synovial fluid is produced. And it excretes it into that joint cavity. Now, there's not much of it in each joint. It's a very, very small amount, but it's enough to keep things lubed up, and it's really important for that reason. The final part of this structure is the periosteum. Remember, this is the connective tissue that surrounds the bone. And so this is part of the joint as well, and is kind of continuous with the joint cavity, or the fibrous layer that surrounds the joint cavity as well. And so we can look at this. So this is the same diagram here that I just showed, but this is what this looks like in an actual cadaver. So this is a frontal section through the shoulder joint. So imagine standing like this, and my shoulder is getting cut off in this plane here. And you can see these structures on the cadaver as well. Of course, they're never as nice and neat and as obvious as the diagram, but you can see here, this is the proximal end of the humerus. You can see this space in between here is that joint cavity.
So, two things. So is the periosteum on the head of the humerus too?
The periosteum, it's kind of continuous with this fibrous layer, right? So it kind of goes up and then like covers the bone here, and then is continuous with this called the articular capsule, which is this capsule that forms the joint cavity.
Okay. And then what did you say? Thinking about like the weeping and moving? What was that?
No, I haven't talked about that yet.
Okay.
Let me get there. Oh, is that on? Oh, it's on this diagram. Oh, I'm sorry. I should talk about it now. Okay. I didn't actually realize that that term was on here. Bless you. So I will come back to that. So this weeping loop. So importantly, this cavity is filled with this synovial fluid. And as you know, cartilage is composed of a lot of water. And so what ends up happening is as you move your joint, it moves some of this synovial fluid in and out of that cartilage, right? So it's you can think of it like if we had a sponge next to a body of water. Water is constantly flowing in and out of that sponge as it's compressed and moved. And what this does is it nourishes that hyaline cartilage. Remember that cartilage is avascular, so we don't have blood vessels going there to deliver nutrients or remove waste or that kind of thing. But in a way, this synovial fluid constantly moving in and out of there provides some of that. So it provides the removal of waste and bringing nutrients and things like that to this hyaline cartilage to keep it nice and healthy. One of the many reasons why moving your body and getting exercise is important for your, in this case, for your joint health as well, to keep that cartilage, that synovial fluid circulating over that cartilage. Question, yes?
Is there like a disorder or a disease where you don't produce synovial fluid?
Where you don't produce synovial fluid? I'm sure there is, but I don't know too much about. Yeah, that would be worth looking up for sure. It would be a terrible disease, for sure, because it would hurt every time you move, basically, and these joints would degrade really quickly. I don't know. We should look that up. Yeah, Dan.
So last thing, you're saying how all synovial joints are is that so? That's sometimes not true. That they have that the synovial joints.
Oh, are all synovial joints are diarthritic? Yes.
Okay.
They are all. Yep. Unless there's a medical intervention, you fuse two of your vertebrae or something like that. And they should be anyway. All right, let's talk a little bit more about the general structure of synovial joints. I just have a few points here I want to walk through. There is a lot of nerves in these joints as well, and this is really important. Anyone that's had an injury to a joint is keenly aware that they're highly innervated, but a lot of these nerves are important for our movement through space. They give our body information about how our joints are moving, the angle that they are at, and where our body parts are, so we can do things with our eyes closed, we can coordinate, we can have these very fine, precise motor skills in a lot of ways. So there's a lot of nerves in those joints that's constantly giving your brain information about what's going on at that joint. The joints also have a rich supply of blood vessels that run to that synovial membrane. And what's interesting is that the way these blood vessels are structured, and we'll talk about blood vessels later this semester, is essentially there's more than one blood vessel that goes to a certain spot. Because as you move your joints in different ways, you can pinch those blood vessels and restrict blood flow. And so essentially you've got this network so that if you pinch off one particular blood vessel, then other blood vessels can deliver that blood where it needs to go. We're not going to get into the anatomical details of that. Just want you to know that it's important that they're structured that way. Otherwise, if you pinch the blood vessel, then you would be restricting that blood flow and you'd have troubles. The last part here, and this is pretty cool, is that it's actually filtrate from these blood vessels, meaning blood that's been filtered, and certain parts of the blood stay in the blood vessels, like the blood cells and large proteins and things, but some of that leaks out, and that forms the basis of this synovial fluid. So synovial fluid is a blood filtrate. We have other examples of that throughout the body. For example, sweat is a blood filtrate, urine is a blood filtrate, and we have one more here, that synovial fluid in your joints originates as plasma in your blood. And finally, that synovial fluid that's formed from that blood filtrate also contains something called glycoproteins. We don't need to get into the molecular details, but they are formed by fibroblasts, and what they do is they help, again, lubricate. They give it that viscous, add to its viscosity and give it that extra lubricating power. Like you think about oil being thicker and goopier than water, and oil, of course, is a good lubricant. That's exactly what these glycoproteins do in that synovial fluid. I'm going to show you a couple examples of synovial joints in the body. I'm going to start with your temporomandibular jaw. And this is the joint that is right up here. If you clench your jaw like you're really mad, you can feel that. It's just anterior to your ear. That's the articulation of your mandible with your temporal bone. If you yawn, I see some of you yawning, you open your mouth wide. You can feel that joint move right in there. That is the condyle of your mandible. So this is a lateral view as if I'm facing this way. You have the condyle of your mandible, and that articulates with this this part of your temporal bone. And it's actually a kind of complex joint. You can do some different motions with it. I mean, of course, your jaw is moving up and down for chewing, but you can also stick your jaw out. You can move your jaw back. You can move it in a variety of ways. And you can see example here of this synovial joint. Now, I don't want to get into too much detail about this. I just want to show you some examples of where these joints are in their body and give you an idea of how they're structured. You can picture the synovial fluid moving around every time that you open and close your jaw. I want to see if there's anything else here I want to talk about. No, I just want to give an example of that. I don't need to get into the details too much here. No, what I want you to take away is I want you to be able to look at a joint, a diagram of a synovial joint, and name the major structures. So this has some structures that are particular to these bones. So for example, the condylar process of the mandible, which you actually learned about in lab, the ramus of the mandible you learned about in lab. But what I'm interested in is seeing examples of this general structure, where it is in the body. And it's a nice one because you can feel that joint. You can feel that move every time you chew or talk or yawn or yell, which we could try if you wanted to. No, you don't? Okay, next time. All right, one other aspect of this I want to cover. I mentioned that the ligaments going through and around joints can be either extracapsular or intracapsular. And these ligaments, whether they're inside or outside of that joint, have slightly different structures. And I want to talk about what's called bursae or tendon sheaths. So these bursae are essentially little sacs of fluid, and they occur in association with the synovial joints. So this is separate from the joint cavity that contains synovial fluid. They're basically like little flat sacs of the synovial fluid, and they act, again, they provide this lubrication, and they kind of reduce friction between the different elements of the joints. And there's two kinds of these sacs. One is called a bursa, which is a flattened fibrous sac lined by a synovial membrane. So basically just like a little sac of synovial fluid, but flattened. Like picture like a water balloon that's not super full and just kind of gets flattened out when you set it down. That's exactly what it is. You have this fibrous connective tissue surrounding the liquid of the synovial fluid in the middle. And then we essentially have the same thing, but just kind of stretched out and wrapping around a tendon, and that is called a tendon sheath. So bursa and tendon sheath are basically, they have the same purpose, same general structure, only they take slightly different form, where the bursa is just this kind of sac. The tendon sheath tends to be longer and kind of wraps around a tendon. I'm going to show you an example of that on the next diagram here. I'll let you get this down first. So here's a diagram of that. This is, again, the right shoulder. No, is that right? Yeah, that's the right shoulder. And you can see, so it's as if I'm standing here. It's a frontal plane right there, my right shoulder. And you can see in green the bursa between the acromion and the head of the humerus there. It's just that little flattened disc. It's filled with synovial fluid. The tendon sheath is basically the same thing. It's just elongated, and it wraps around that tendon. So you have this tendon that attaches the biceps brachii up to your scapula, and this tendon wraps around the joint, and you have this flattened, elongated bursa that's called a tendon sheath around that tendon, so that when you move your arm, that tendon doesn't bind against the bone or anything like that. It allows that tendon to kind of slip freely as you move your arm. And that's, of course, super important, because not only do we want the bones not to rub on each other, we don't want those tendons and ligaments to be binding on each other either. And you can see a number of other parts of the synovial joint that we covered earlier. You can see this articular cartilage, which again is that hyaline cartilage that surrounds the bone of both the scapula and the humerus. We've got the actual joint cavity here in yellow. Again, that's where the synovial fluid is. You've got this fibrous layer surrounding the joint capsule, etc. So bursa and tendon sheath are the takeaway messages here.
I looked up, by the way, to see if there's any disorders where you don't produce synovial fluid.
Yes, is there?
I can't find anything on it.
Okay, thank goodness, because that sounds terrible.
Only disorders where your joints get inflamed, or you have cartilage that grows in your synovial joints, or your synovial fluid, and then breaks off inside.
Yeah, I think that was going on with my hips, actually. I'm familiar with that. The cartilage can degrade, and then the whole joint just goes to hell. Yeah, that's good times. Yeah, it would be, I mean, because I can't imagine if you didn't have that synovial fluid, like, from a very young age, your movements would be so restricted and painful. Like it would be pretty terrible. So that's good. Mm-hmm.
So in terms of like some of these parts are like after these growth plates fuse on this person, would that like would the material and some of that like change, or would it just like elongate or grow with it as the long bone kind of grows? Or?
Yeah. So what's actually interesting is that this came up with my daughter recently, is that when you're growing, when you're young, especially, say between like 10 and 15, when you kind of hit the growth spurt years or even a little bit older, what often happens is that your long bones at the epiphyseal plate grow quicker than anything else, which is why you get growing pains. I don't know if any of you have had growing pains like in your knee. I remember when I was a kid, I used to get in my knee, and it was like the worst feeling. But what's happening there is that the bone is growing faster than everything else. And so all those tissues are essentially being stretched and have to like catch up to accommodate the new size of the joint as that bone grows.
So like the things that are not as good as that healing, I'm gonna feel more of that, or like, so like the bone wouldn't be the part that hurts, it would be maybe like the tendons or something.
Yeah, exactly. All of that stuff is basically getting stretched as the bone grows, and then they'll eventually grow and accommodate that, right? That's why growing pains don't last forever, and that the joint needs to grow and accommodate for that. But things grow at slightly different paces, and that leads to that slight mismatch between the size of the bone and the rest of the joint tissues. Yeah, I saw another hand. I think it was Chris. Did you have a hand up? Now you have to ask a question though. No? You sure? Okay. All right, let's talk about, let's see, what do I have here? Let me just look and see what I'm going to cover here. Okay. Oh, there's just a couple more things to cover here. Okay. So we talked about synovial joints. We can categorize them further, and this is actually perfect. This ties in what we did in lab yesterday. We can categorize these synovial joints by the number of planes or the number of axes in which they can provide movement. And so we have what's called a non-axial joint, which movement doesn't occur around a particular axis. So a good example of this would be, let's say, the joints of your ribs and your sternum. There's some movement there, but it's not necessarily in a particular direction. It can be just kind of a little bit each way depending on what's going on. We then have uniaxial, which is when movement only occurs in a single axis. So a great example of that is your elbow, right? You can move your elbow this way, you can move it that way, you can move it just in this one direction back and forth. I can't move my elbow left or right, and I can't move it in any other direction. It's uniaxial, only moves one way. We have biaxial, which is when movement can occur across two planes. So a good example of that is the condylar joint in your finger. So let's take my index finger as an example here. I can move that index finger up and down. Actually, you all can try this. Move it this way, and then I can move it side to side too, right? So it's biaxial. I can move it up and down or side to side in two different planes. It's fun to see everybody doing that. And then we have something called multiaxial. So these terms are pretty intuitive. Non, uni, bi, and multi. You can guess what multiaxial means. It means they're on any plane. So a great example of this is like your shoulder joint. I can move this up and down. I can abduct and adduct my arm. I can flex it. I can extend it. I can move it in all directions, and I can circumduct it even. I can go in all different planes. I just go crazy with my elbow. So I've got that nice shallow glenoid cavity. Fits the head of the humerus and provides a huge range of motion for that joint. Yeah, this ties in nicely to lab. That's all I was going to say there. Ethan, go ahead.
What was your example of a non-axial again?
Non-axial would be something like the joints of the ribs with your sternum, right? It's not necessarily moving in any particular plane, but it's just providing give as other parts of the body move, essentially.
Do those have, so I'm assuming those have synovial fluid?
Those are synovial joints. So if you recall, I talked about the cartilaginous joints, synchondroses between the first rib, articulating with the manubrium, then the rest of your ribs as they articulate with your sternum. Those are all synovial joints. Question, Grace?
Which one was the biaxial again? With your finger, can you not move it like?
You kind of can. So that's a little bit. I can see like that's definitely a bit of a gray area. Okay. But primarily you can move it up and down and left and right. It's not as good at moving around. You kind of can, but it's not like something like your shoulder or your hip where you can really move it around. So I found that definition a little bit unsatisfactory, that distinction between biaxial and multiaxial, to tell you the truth. You also have a joint here, a particular kind of joint between your carpals and the metacarpal of your thumb here. That's biaxial as well. It's hard to see, but you can kind of move it in this plane, and then you can move it in that plane too. And that came up in lab as well. Bless you. All right, let's talk about, this is actually the last thing I want to talk about. Okay, so synovial joints are highly movable. They're diarthritic, freely movable joints, which is fantastic if you want to move around a lot, but the trade-off there is the more something moves, the less structurally stable it is. We find this trade-off everywhere in our body. So for example, your skull, super structurally stable, right? We want it to be. We want to protect that brain. The trade-off is there's no movement there, right? And that actually becomes a very functionally important trade-off when you think about something like meningitis, where if you get an infection in the tissue surrounding your brain, and generally with an infection, things expand, that's got nowhere to go, and that's bad news. That's the problem with an infection up there, is not necessarily the infection itself, but there's no room for it to swell. And as soon as it starts swelling, that cranium, your skull, is very immovable. And so the brain tissue can get damaged because it's under this immense pressure, right? So that's a functional trade-off between mobility and stability. In this case, we're opting for stability instead of mobility. Counterexample to that would be something like your shoulder. Super mobile, right? You can do all kinds of cool stuff with it. You can play throw ball. You can do whatever. And the trade-off is that it's easily dislocated and it can get injuries there, and you can move the joint. I know I said throw ball. It's a long story behind that I'm not going to explain, but it's kind of funny. But the trade-off there is that you can disarticulate that joint easily. So we find this kind of trade-off throughout the body. With these synovial joints, we find a couple different factors that contribute to their stability, even as they're highly movable. So we have these articular surfaces. So for example, at the hip, we have this ball and socket structure. At the elbow, we have the olecranon of the ulna wrapping around that trochlea of the humerus. The ankle, we have the two malleoli of the tibia and fibula that provide that stability for that joint. Now, those are some examples in the body. There's not too many examples of that. Those are some big obvious ones and some big obvious joints. But actually, in most joints, we don't really find that structure is playing a major role. But in a few places, it's really important. So few places it's important, but it's not too common. We also find that ligaments add to the structural stability. I talked about the knee before. Ligaments are very dense and tough. They can stretch just a little bit though, and then they can break. And if they break, that's a problem. They don't heal very well. But they do provide that extra structural stability. So ligaments in your elbow, your knee especially, these are uniaxial joints. So your knee is a good example of a uniaxial joint. It's only moving in this one direction. If something hits your knee and you move it like this, that's bad news. That's a common injury for like physical contact sports, like football or something like that. You get hit from the side and that bends the knee in this other plane. That can really do damage because these ligaments stretch and can break. And finally, muscles. Muscles provide movement, but they also keep those joints in place, and they keep everything kind of structurally where it should be. And so all of these muscles extend, your muscles extend over joints, or the tendons that attach to those muscles extend over joints, and that muscle tone can improve the stability of those joints. So muscles not only providing them, but the force of contraction that provides movement, but it's also adding to the stability of those joints and keeping everything where it needs to be. And that's it for joints, except for lab stuff. Dan, question?
Yeah, so it would say, like, in terms of joints, you said that like less mobility is pretty synonymous with like more stability.
Generally, yes. Yep.
So like, would an exception be like someone who is like doesn't stretch as much as compared to like someone who's like super flexible? The person who didn't stretch and wasn't flexible, they were more stable in a way, or does that not even apply in that?
Well, I guess kind of, although in that case you're looking at more of flexibility of the muscles and the ligaments, right? And so the trade-off here in that case actually is a good example is these muscles and ligaments add to stability, but we also want them to be able to move somewhat, right? If ligaments didn't stretch at all, then they would just snap under the slightest pressure. If your muscles are tense, even as they go over the joint and provide stability, we also want them to have some flexibility as well so that they can stretch and absorb that impact rather than just destroy that connective tissue or even damage the bones of the joint itself. So again, that's a trade-off there between stability and flexibility, or in this case, stability and movability.
So that's just more of like try to find a middle ground with this. No.
Well, it depends on which joint, right? And some places you want to find a middle ground, but some places you want to err all the way on one side or the other, like your skull, right? We err all the way on the side of stability for a skull. There's no flexibility there except for when you're 6 months old, less than 6 months old. That's the only time in your life generally where you're going to face a situation where your head's going to get smushed and you want to make sure it can pop back okay. Unless you're Meatloaf. Rest in peace. He got his name because he used to have like his friend back his car up and like put his tire of his car on his head. And they said that he had meatloaf for brains. Do you guys know the story? Yeah. Meatloaf, the singer, just, yeah. And which, yeah, anyway. Yeah. Probably lived up to that. So he was definitely erring on the side of stability rather than flexibility. All right, that's what we got. Exam 1 is Friday. Remember, it's going to be in Blackboard. It's open all day, 7 to 11. This coming Friday. This slide you've seen, this information is on your class program about what we're covering. Again, it will cover everything in the course up through Monday. Whoa, hey, easy fella. Let me get you a little more information here before you pack up or as you're packing up. Here we go. I want to remind you a couple of things. See your class program today for some study tips about what will be on the exam, recommendations I have as to go over things. There's no additional program for Friday or Monday this week. We'll just start things Monday with muscles and get into a whole new unit. So your only focus here is the exam on Friday. I want to just add one quick thing as well. The exam is set up. You have 50 minutes or 60 minutes, I said, in Blackboard. If with this exam or any exam you have a technical issue, you're in the middle of the exam and your internet goes out and your computer blows up and your cat pees on your mouse, whatever, don't freak out. Just email me, let me know. We'll always sort it out. I want you to focus on the material and learning human anatomy, the technical side of stuff, like that crap happens, and I just don't want that to be a cause of anxiety or stress. So if anything like that ever happens, just let me know, and just know that we'll figure it out and I get it, okay? Good luck on the exam. Email me if you have questions between now and Friday.